Hello. We're going to start. Good afternoon, everyone, and thank you very much to the organizers, Delvis, Charo, Luis, for inviting me to participate in this meeting, this new edition, this important international meeting. My name is Dolores Isla from University Hospital Lozano Blesa in Zaragoza, Spain. And it's my pleasure to chair the session number 3 of this meeting with the title Metastatic Non-Small Cell Lung Cancer Without Driving Mutations. And I'm very delighted to share this session with my co-chair, Javier de Castro. Javier.
Thank you, Lola. It's a pleasure for me again. And also, thank you very much, the organizers, and congratulations for this amazing meeting. So we are going to start the second part of the first day meeting, and this is a very complicated session because we are going to start after the lunch that sometimes is something dangerous. So I think it's a very interesting topic because we are going to talk about what is the options beyond the first line. So the first speaker is Joachim Ertz, from Erasmus Medical Center in Rotterdam, who is going to talk about the state of the art at the moment on second-line treatment.
Buenas tardes, es feliz honrado de estar aquí. Muchas gracias a los presidentes. And now I'm switching to English because otherwise I get into trouble. But not for me, but for the other speakers, right? So I had the honor to speak about second line nowadays. So it's indeed not talking about what's there, what's upcoming, but only what's nowadays. So I don't know why I got this task, because as you know, it's not really the much of development for what we have in second line nowadays. So these are my disclosures. And I want to start on presenting the ESMO guideline, which you probably all know, and but this is where it starts, and it gives the overview about second line treatment. So I think we know now in patients with high PD-L1 expression, we have the option to start on monotherapy with one of the PD-1, PD-L1 inhibitors, and then after progression, we switch to standard combination platinum-based chemotherapy. On the other hand of the spectrum, we have those patients with a very bad performance status, PS2, and have low PD-L1 expression, where in general we start on monotherapy, chemotherapy, and in those patients who got some kind of an improvement in their performance status, when the performance status is 0 to 2, we could switch to PD-1 or PD-L1 inhibition as a second-line treatment. But the largest proportion of our patients, as we are quite aware of, are those patients having a performance status 0 or 1 and have any kind of PD-L1 expression. As discussed, patients with high PD-L1 expression can also get chemo-IO as their first-line treatment. So in those patients where we already have given our most effective treatment all at once, so both the PD-1 but certainly the platinum combination, in those patients, when patients have disease progression, we're only left, certainly in patients with adenocarcinoma, when they got pemetrexed as first line, and in patients with squamous cell carcinoma, they were only left with docetaxel, and there is, and I will come back to that, potential, you can combine that with anti-angiogenic agents. So this is what it is, and then I thought, well, I'm going to look at PubMed, whether I missed something in the last years which has developed, and then I came to this very recent publication in Journal of Clinical Oncology, so very high impact journal, and this is a publication of Dr. Shepard, and then I was a bit surprised, and it's a prospective randomized study of docetaxel versus best supportive care, and then I thought, I've seen this one before, and indeed it was just celebrating GCO 40 years, and looking at PubMed, you have the same publication, which is there two times, and this is the original publication from 2000. So, but it's very sad to see that we still are talking about second-line treatment in non-small cell lung cancer in patients, and we're talking about treatment which is almost 25 years old, and we haven't improved that much. And this is what this study was based on. So this is what the results of the study were. So you see an overall survival benefit in patients getting docetaxel as second-line treatment compared to best supportive care. And this is what still is in the clinic. And it took around 14 years before the first positive studies, and there were 2 studies coming at the same time, showing the additional effect of an anti-angiogenic agent. So in these studies, docetaxel was compared to adding an anti-angiogenic agent. And on the left, you see ramucirumab, which is an antibody, and this is in all histologies. And in all histologies, there was a survival benefit in those patients. On the right is a study with docetaxel and nintedanib, and this study was only positive in patients with non-squamous histology. And this led to the improvement of anti-angiogenic agents in combination with docetaxel as second-line treatment. And there was a lot of debate around that time. In some countries it was approved, in some countries it was also reimbursed, which is also an issue with these drugs. But still now, as you have seen, and you will see also in the other talks, the comparator arm in general is now docetaxel and no longer in combination with those anti-angiogenic drugs. There are no data proving that they're negative, but I just think that it's not additive enough with and adding toxicity, of course. Then, as you know, and that's still, then we came into the IO era, which was a year later. And of course, we sometimes forget, but the IO started as a second-line treatment, showing the improvement of above docetaxel of those PD-1 inhibitors. And after that, and this was also this morning highlighted by Delvis, after that, and this is a slide from a publication in Cell 2017. After that, there was the idea that we just combine some kind of IO with another kind of IO, and these are all the studies where were at that time ongoing, and the question was who is going to be the winner. But as you know, all these trials failed. And there was a lot of patients have been entered into those studies, and ultimately all of these agents were proven negative. And it just has showed us that what we thought in 2015, that we can see the immune system as a switch. When the patient is not responding to one switch, you just add another switch. But we know now that it's a lot of switches altogether, and we have to see, and it's also maybe depending per patient, that the number of switches on and off is different. So that is how we have to look at the patient and also how we can improve second-line treatment. But that will come in the following talks. Well, has anything changed in standard of care? And I said docetaxel is the comparator arm which is now used, but in some countries the standard of care has changed based on this publication, which was from last year. And this is on adding TT fields, so tumor treating fields, to the standard of care at that time. For those not familiar with what tumor treating fields is, this is not a drug, but it's a device. So it's 4 patches which are placed on a patient, so one in the front and one of the back, and it's connected to we'll call it a battery, and it generates electromagnetic fields forth and back in the patient, and the concept was that that has an effect on the mitosis of the cells and leads to increased cell death. So this was tested in a trial where patients could be included who had platinum-based chemotherapy, so no IO drug, and it was compared the standard of care, which either was docetaxel or immunotherapy, plus or minus TT fields. And this study was positive for the primary endpoint, so there was an increase in the overall survival of those patients. And interestingly, as you can see, those patients who were treated with docetaxel, so those patients pre-treated with chemo-IO, the advantage of the device was less, and it was more present when patients were treated with immune checkpoint inhibitors. And this could be, and I'm not going into detail, but this could be related to potentially also an immunogenic activation, like we know that radiotherapy can do during treatment. So, but this is one of the treatments. The other positive trial, and I think Federico, you will cover that, so I don't put any data on this, not to spoil your presentation, but there was another positive trial on antibody drug conjugates, which you will hear about later. So, however, there's somewhat more which is not covered in the ESMO guidelines and what we do in clinical practice. So the last part of my talk is not really supported by very firm data, but I think for all of you working in the clinic with patients and having as an only option when they progress docetaxel, you are stressing what you can do with your IO drug. And that is what I want to cover here. So I'm talking about oligoprogression, treatment beyond progression, progression after completion, and also what happens when you treat patients with the 9LA schema, so 2 cycles of chemotherapy and combination IO. So this is on oligoprogression, and this is just a patient which I treated, and there's no real large series proving that it's effective, but this is a patient who was with a metastatic non-small cell lung cancer, and we treated him with pemetrexed pembrolizumab, had a partial response after 4 cycles, and then after 6 cycles of maintenance, there was an increase in a pancreatic lesion as the only lesion who was progressing. So what we did is we asked the radiotherapist to irradiate that region, and that was done, and the patient is after that continuing on his treatment. Is this, and we have, of course, everybody of you, I think, has some kind of patient in whom you did this, and this was effective. And on the other hand, you also have patients whom you treat, and then they have in a couple of cycles over progression overall. But still, I think this is a valid treatment in patients who have a response and have only at one side progression of the disease. The other thing is, what are we doing with patients who are on treatment and where you see that there's progression of the disease, but it's not going that quick, the patient is clinically fit. Do you continue on treatment or do you switch? Well, this was studied in the OAK study. So the OAK study is a study of atezolizumab, but this is in second line. So patients were treated in second line with the PD-L1 inhibitor, and there was a choice in those patients. They could continue on the atezo after they had RECIST progression when they were on a good clinical shape. And about 50% of those patients did continue with the atezo, and the other switched or did not get any therapy. And of course, there's a lot of biases, so I'm not saying that it's better, but I'm just saying that those patients who were treated beyond progression got a 12-month overall survival of 53%. So that maybe gives a hint that this could be effective. And you can question me and tell me, well, is this just not the natural behavior of the disease? As I told you, it's not that I'm stating any firm data, but it's just giving an idea that this is also an option. The other thing which we know is that, are we restarting patients after completion of treatment? So you know that in the studies, patients are treated 1 year, 2 years, and then the drug is stopped, and those patients who develop progression after the interruption or the stop of the treatment, when you restart it, can they have benefit again? And this was the first data of showing this from the keynote study, and it shows that when you restarted the treatment, that could be effective in patients, again causing them to get partial responses. And this is also further investigated by Delvis, one of our co-chairmen, and they looked into all the different keynote studies that those patients, after completion of the IO or chemo IO, when they got recurrence of disease and you restarted the treatment, what was the clinical effect of this? And you can see in the left that the overall response rates are rather low, and on the other hand, you can, from the 6 months overall survival rate, it's about 85%. So again, it shows you that restarting treatment in those patients who did well is certainly an option. The other part is the question of what do we do with the patients who you treat with the PD-1 anti-CTLA-4 in combination with 2 cycles of platinum chemotherapy. And in the original study, after progression, you can see here that 20% of patients did receive a platinum doublet chemotherapy again. because we can imagine that those patients only had 2 cycles of chemo, platinum-containing chemotherapy, so there is a rationale of giving them more platinum doublet chemotherapy. So that's another option, I think, in patients when you use this regimen, that you can restart on the platinum-based chemotherapy. So the other question which I must answer is how many patients do receive this, and I must say I searched a lot, but there's no firm data, real life, stating how much patients do get second-line treatment. And I certainly think that's also depending on the options you have. Given that, and as we have the discussion in our outdoor clinic with our patients discussing the option that it's only docetaxel, that makes it a rather more difficult decision. When I did that 10 years ago and I could offer them immunotherapy, then the percentage of patients getting second-line treatment was much higher. So I think there are no data, but you can see, and that's also what you can see from this trial, which is a very selected population, and also in this population, 40% or 50% of patients did get second-line treatment. So what we are treating, even in a highly selected population, is a low percentage. And of course, it's also a bit differing. So now, when we have for KRAS G12C, and that's on the program tomorrow, but if you have as a second-line option a TKI against this mutation, it probably also makes you more prone, and also the patient more prone to be treated. So, for me to conclude, I think what we can say, it's still a high unmet need in second-line treatment in wild-type non-small cell lung cancer, and the treatment decisions should be based on your first-line treatment. And with that, I'd like to thank you for your attention.
Yeah. Thank you. Thank you. Joaquin, come here, please. Yeah, the next speaker is Yaruska Naidoo from Pulmón Cancer Center in Dublin, and she's going to talk about a very key subject, mechanisms of resistance to immunotherapies, but this time even in early stage. Yaruska.
Good afternoon, everybody, and thanks for sticking with us for this part of the program. You'll forgive my sniffles from my 4-year-old. So today I'm going to talk about mechanisms of resistance to immunotherapy. As many of you know, we've heard many presentations on this topic, a little bit different, delving more into the science maybe rather than the clinical trials, but of course moving towards how the science can inform how we might approach clinical trials. So this is a figure that we've seen a lot. We're aware that the clinical outcomes from immunotherapy can vary widely, that we can get these unusual response patterns like hyperprogression and pseudoprogression, but that while a proportion of patients get durable benefit, the vast majority of our patients develop primary resistance where they don't have any response to immunotherapy at all, or a short-lived response in the form of acquired resistance, and that this occurs in approximately 60 to 80% of patients. And really this leads us to 3 main questions. First, are these patterns driven by the same processes? So what are the mechanisms underlying these patterns of resistance? Second, how do we rationalize these approaches in clinical trials? Can we use our understanding of mechanism to define resistance clinically? And lastly, what is our experience thus far? What have we learned about trials from IO resistance and other disease setting? And my colleague, Dr. Rosario, will talk about that very soon. So as you know, this is a figure from Ira Melman and colleagues in which the cancer immunity cycle is summarized. And this really tells us about the different steps that describe the interaction between a tumor cell, the innate immune system, and the adaptive immune system. And there are various steps within this cancer immunity cycle at which the process of resistance can occur. This can also be summarized in a different way of thinking into tumor intrinsic mechanisms and tumor extrinsic mechanisms. So I'll synthesize some of this for you from the published data. So the very first step in order to generate an anti-tumor response is for the tumor to produce antigen. And so in the development of resistance, either primary or acquired resistance, if there is an absence of antigenic proteins through low tumor mutational burden, which we've heard about before, or high intratumor heterogeneity, this can result in non-response to immunotherapy. And we see here classically non-small cell lung cancer is associated with a slightly higher tumor mutation burden, but subsets like EGFR mutant lung cancer, a low tumor mutation burden, and this varies with different oncogene-addicted subsets. In that first step, antigen may be produced, but it also needs to be recognized. So another mechanism of resistance that has been described by many groups, but is well annotated here by Elsa Anagnostou from the Hopkins group, shows that in certain instances there can be a failure of antigen recognition due to the loss of tumor-associated neoantigens. And in this series of 90 patients who developed acquired resistance at Hopkins, we see that 4 of them lost specific neoantigens, therefore yielding the hypothesis that a subset of candidate mutation-associated neoantigens present in the baseline tumor may be eliminated at the time of resistance to immune checkpoint blockade. So once we have our antigens and they are recognized, from there they need to be presented. And usually they are presented in the context of MHC class 1 molecules. However, there are various mechanisms that can lead to this step of antigen presentation not happening. For example, the loss of or mutations in beta-2 microglobulin. And this has been described by Scott Gettinger and colleagues. This is the series from the Yale group in 14 patients, in which we saw one of these patients developing a homozygous deletion of beta-2 microglobulin. So we can see really the antigen processing machinery is also key in making sure we do not develop acquired resistance to immunotherapy. So there are 2 more steps in this sort of tumor intrinsic mechanisms of acquired resistance. The first is that the tumor itself, the tumor cells, may release factors that upregulate pathways that exclude T cells from coming into the tumor microenvironment. So tumor cells themselves may upregulate MAP kinase, PI3 kinase, the Wnt beta-catenin pathway, and the IDO pathways. And all of these pathways lead to T cells not coming into the tumor microenvironment, and again, the process of acquired resistance. And then lastly, the T cells might actually be in the tumor microenvironment, and still, tumor cells may release factors that now downregulate other pathways, or mutations that downregulate other pathways that inhibit the tumor microenvironment from being successful. And one of these mechanisms was first described by the laboratory of Tony Ribas in the context of melanoma, and this has now been recapitulated in the lung cancer field, where we see here in the seminal paper published in the New England Journal of Medicine that a subset of patients with melanoma develop mutations in the JAK-STAT pathway. This, therefore, results in JAK loss, and from here, downregulation of the interferon gamma pathway and an unfavorable tumor microenvironment. So from here, we might switch to tumor extrinsic mechanisms. So these are mechanisms from cells outside of the tumor cells that result in IO resistance. This is probably the mechanism that we've heard the most about, this phenomenon of T cell exhaustion, that chronically upregulated T cells start to express other markers like TBET, EOMs, and others that indicate that they are exhausted and do not necessarily function optimally in the tumor microenvironment. These markers are often expressed in the context of chronic viral infection and are also co-expressed in cancer. We can see inhibitory checkpoints like VISTA, LAG3, and TIM3 may also be co-expressed, and the presence of immunosuppressive other cell populations, like tumor-associated macrophages and Tregs, are also implicated. Of course, we know all of these mechanisms have been interrogated in the context of clinical trials. However, we have had variable and mostly negative experiences from really only isolating one of those mechanisms. And then, of course, there is this mechanism of the host environment, which I think is something that we are only really learning about in a very early way. So we have seen now there are 5 published papers on both the gut and the lung microbiome, and how these may impact the tumor microenvironment and may impact the ability to either mount response or develop resistance to immunotherapy. We see here that most of these are prospective studies in which samples from stool samples or lung samples have been collected and assessed by 16S or metagenomic sequencing, and they identify basically that there are certain microbes, for example, Ruminococcus and Akkermansia, as well as a high alpha diversity that's associated with response to immunotherapy, so the good actors, and some that are the bad actors associated with non-response to immunotherapy, low alpha diversity, and bifidobacterium being some. This is where the first foray into understanding early stage has actually surprisingly come from. There have been no comprehensive analyses of the genomic basis of acquired resistance to immunotherapy, except with regard to the gut microbiome. So this, of course, is Tina Cascone's phase 2 NeoStar study, the first iteration, in which patients could receive either Nivo alone or Ipi-Nivo in the neoadjuvant setting for resectable lung cancer. And in the study, she also did a deep dive microbiome analysis where she identifies certain microbial species that are associated with non-response to immunotherapy. And this includes Lactospiraceae, Oscillospiraceae, and Coprococcus. So still something that we need to learn about, but really some of the initial data on this. So moving to what we understand clinically. So this is a paper by A.J. Schoenfeld, Solange, and others, showing that up till 2020, really our understanding of the mechanisms of acquired resistance was very limited. Only 58 unique patients had been comprehensively studied based on pre- and post-PD-1 samples to understand the mechanisms of resistance. And we see here that this could occur through any of those steps that we already annotated through the cancer immunity cycle. But thankfully, in the last couple of years, there have actually been several large papers, and actually some only just in the last couple of weeks, which I'll summarize very briefly. So this is one of the first experiences, again, published by Elsa Anagnostou and the Hopkins group, evaluating genomic features of resistance in about 90 patients with lung cancer. And in this, she describes an enrichment in receptor tyrosine kinase genes that are associated with non-response, and these include MDM2 and 4 copy number variants and PTEN loss that's associated with primary resistance, and KEAP1 mutations, which are associated with non-responders. And these associations remained statistically significant even when correcting for TMB and smoking status. This is a more recent analysis conducted by the Stand Up to Cancer Mark Foundation, which was led by Justin Gaynor and colleagues. So I'll walk us through the data. So this is a very large data set, 393 patients with non-small cell lung cancer, 309 exomes, and 152 RNA-seq samples. And of these, 104 patients had acquired resistance or progressive disease. And effectively, what this group demonstrates, the very top graph is a volcano plot of a logistic regression of the oncogenic driver mutations that are associated with either response or resistance. And we see that ATM mutations are associated with response, EGFR mutations associated with resistance. The lower volcano plot shows the logistic regression for amplifications. And what we see here is that TERT amplifications were associated with resistance to immunotherapy. They then do a very nice deep dive heat map of all their gene expression data and compare it to all the other published gene expression data for response and resistance. And what they show in the purple square is that genes and pathways from bulk RNA-seq that are associated with wound healing were associated with non-response to immunotherapy. So really a number of targets here that could be interrogated for resistance to immunotherapy. Another paper that was published in the last couple of weeks by Hellman and colleagues adds another dimension to the story of acquired resistance. So this study was a collaboration between Memorial Sloan Kettering, the Swanton Group, and AstraZeneca. And in this study, again, whole exome data and RNA-seq data are combined in 42 samples. And what's unique about this analysis is not only do they assess resistance at the patient level, but for the first time, they assess resistance at the lesion level. So do we see differences in acquired resistance by liver, bone, lung, and other types of lesions? And what this analysis shows is they separate lesions into those that are interferon gamma stable or interferon gamma increasing. And they show that actually in lung cancer, there are lots of T cells in the tumor microenvironment in the vast majority of cases. There's an upregulation of the interferon gamma response, but it is a suboptimal upregulation, resulting in T cell exhaustion and non-response. And again, what they show is that in a subset of these patients, there appears to be an upregulation of DNA damage, repair genes, and oxidative phosphorylation, and that this is a novel mechanism of acquired resistance in a subset of these patients. The last paper, again, just published a few weeks ago by Biagio Ricciuti and colleagues, evaluated 82 patients with pre- and post-PD-1 samples and looked at acquired resistance from a genomic, immunophenotypic, and an HLA perspective. From a genomic perspective, he identifies in about 30% of patients we see genomic alterations associated with resistance. And this includes STK11, the antigen-presenting machinery, beta-2 microglobulin, JAK1 and JAK2, as well as mTOR and KEAP1. And then from an immunophenotypic perspective, he shows that in those patients who have these genomic alterations, there is downregulation of CD3 and CD8 T cells and an increase in the distance between tumor cells and CD8 T cells by multiplex immunohistochemistry. And then lastly, he shows in a separate group of patients that there is HLA downregulation by immunohistochemistry as well. So really that multiple different mechanisms may coexist in patients with lung cancer who develop acquired resistance. So how do we translate this into the clinic? Where we would aim to be is to take all of these factors into consideration and have a tailored response to how we approach these patients. But the reality is, this is an initial foray, but really we have limited knowledge of the mechanisms of resistance at the patient and lesion level. And right now we're guided by the clinical scenario. What is the pattern of progression? How do we define resistance? And from here, the trials that we use in the second or third line setting really are agnostic of the resistance mechanism and are not tailored to the mechanism that may be at play in the patient. So right now, there are two consensus definitions that have been developed for immunotherapy resistance. The first really was based mainly on the melanoma experience led by Harriet Kluger and colleagues, a SITC task force, which uses the cut point of 6 weeks for primary resistance and 6 months of immunotherapy for acquired, or they call it secondary resistance. A follow-up set of definitions was developed by the ESMO group, and in this, they focus on lung cancer and would make the assertion that combinations can be grouped together, that really patients who have acquired resistance must have had an initial response to therapy, and that acquired resistance can occur even within the 6 months of the last IO, given that the receptor occupancy of PD-1 is an extended period of time. Of course, despite these consensus definitions, there's still no consensus, because despite those presentations, we see in the lung map study where there was, in fact, some benefit of the PD-1 VEGF combination in the eye-resistant setting, they used a definition of 84 days or 12 weeks after ICI initiation for acquired resistance. So really, I think the consensus is there's no consensus, and we probably need to work towards building consensus clinically for the definition of acquired resistance. This is a lead up to Rosario's presentation on all the trials in eye resistance. A pity Hoss is not here, because this is certainly the facial expression I think many of us have had when looking at the outcomes of clinical trials in the setting of eye resistance, and hopefully more positivity on the way. Thanks very much.
Thank you, thank you, Yaruska. Finally, Dr. Garcia Campello, that's all you knows, who is going to review new options beyond the progression of IO.
Okay. Once again, many thanks for being here. Good afternoon. After lunch, I think this is a hard session. And thanks the previous speakers, because I think they have pictured the reality of and the complexity of this situation we are having. Those patients who progress after conventional immunotherapy, mono combinations approaches, what are the options when we talk about novel combinations in this scenario? So we know that immunotherapy is everywhere. It has been a long, long way. I think we all agree, all of us who treat lung cancer patients and all cancer patients, that immunotherapy is something for cancer equivalent of penicillin. We have incredible results in the first-line setting, but it's also true that we have reached a kind of plateau. And we have been talking about this during the previous session and this one. We got long-term survivals. We are trying to improve the results in the first-line setting. Delvis talked about the multiple options that are being tested. But at the end of the day, this is what we get. This is where we are today. Sometimes I have the feeling that we are in a similar moment that when we used to do all these combinations with platinum doublets in the first-line setting. We are like stop at this moment. And as Dr. Naidoo mentioned, the main issue we need to clarify is try to understand much better the tumor we are treating, the patient we are treating from the very beginning, the acquired resistance, the primary resistance, because this is the only way we have, although it's really complex, as you have mentioned, it's the only way we have to move forward. So many options are being tested. So I will not go into detail in all these options. Basically, I will reach all the potential, and there are many potential combinations with CPIs and other new agents. Also, we have cytokines, the concept of microenvironment manipulation, vaccines, the fascinating world of T-cell therapies, and Federico will address the topics of ADCs and be specific. So let's start with this idea of manipulating the immune system. We know that PD-1, PD-L1, anti-CTLA-4 have been a successful story. So let's try to analyze and let's think we are driving a car. If we can modulate and get better outcomes with this idea, no? We can use agents that can block the inhibitory signals. We also can use agents that can stimulate these co-stimulatory signals. We will talk about a little bit these new agents. We can also try to modulate the road. Many options are also being tested here, like VEGF, as Dr. Naidoo mentioned, cytokines, and also the microbiome modulation. And finally, the real power of having the steer of the car, and with all these potential options with CAR T-cells, T-cells, and vaccines. So let's start with this, and let's see what we have. Also, Delvis anticipated some of these results. We have different agents, anti-TIGIT, anti-TIM3, anti-LAG3. We have actually multiple me-too drugs with this the same mechanism of action. And these agents have been tested in very early trials in those patients who progress to conventional therapies with immuno or immuno plus chemotherapy, the concept of continuing the PD-1, PD-L1 inhibition and adding like vibostolimab, anti-TIGIT, or anti-TIM3 with sabatolimab, or anti-LAG3. As Delvis mentioned, the results are really poor. And even with those results, we have put these agents to phase 2 trials. And just one example of one of these trials that also he mentioned is the KeyVive 002. This trial has tried to demonstrate the value of this agent combined with pembro and docetaxel, or without docetaxel, and again, docetaxel is still winning the game. The trial is negative, no significant differences in terms of PFS, so despite we don't like docetaxel, it's still the one we need to beat. This is also a new option. In this case, it's a bispecific antibody targeting PD-1 and TIM3. The preliminary results again, I don't know what to say. I don't know what to say. Okay, it's a heavily protected population. The numbers are very small. It's some kind of signal in a few number of patients with prolonged duration of treatment. But the truth is that we cannot say this is probably, wow, the next step in the second-line setting. This is another strategy that is also being tested, monalizumab blocking NKG2A. And there is a phase 2 trial trying to, also based on the results we got from the COAST trial in a stage 3 population, promising results, but still not so relevant in terms of changing our daily clinical practice. So let's move forward to the idea of activate the activators. Here we have also different options, different targets, and different trials. Again, and I borrowed Dr. Naidoo this slide. Again, the results are really poor. In fact, some of these programs have been closed with ECOS. as I mentioned, some of these programs are stopped because of the bad results. We also have this agent, and look at the first one, the sample, overall response rate, 0%. So this is something quite easy to say. At least from my point of view, these results are really disappointed. What about the idea of modulating the tumor microenvironment? I think this is very tantalizing. This is the only one slide I have regarding the combination approaches with agents that can influence in this tumor microenvironment, because I think this is going to be addressed in the next session. But again, we have 3 phase 3 trials. Again, docetaxel is winning the game. So let's see if I can see the light. Here, no, at Kant, cytokines, multiple options, multiple agents, again, multiple fails. And probably, and this is too early to say that is something that is going to be successful, modulation of microbiome can be an option. Here, you can see some examples of what is going on in this sense, mainly in patients with melanoma. But we have looked at melanoma for many, many years. Why shouldn't we keep doing that? But it's difficult to say that we are doing things properly. There are some potential options like this one, in this case, using a combination of anti-PD-1 with agents that can interfere in the DNA pathway. And we have a phase 3 trial trying to confirm that combination of durvalumab plus ceralasertib is better than docetaxel in previously treated population. More combinations, and let's move forward to this scenario. Vaccines, I think vaccines are a really fascinating area. We know that the power of vaccines in the global health population, we know that we can prevent cancer with some vaccines, and why not we should treat cancer, metastatic cancer with vaccines. This is not a previously treated population, this is first-line setting. But this is just an example. A small number of patients, they were treated with this vaccine combined with anti-PD-1 and also chemotherapy. The results are, well, I would say that at least we see some signal. But again, I don't know how is the feasibility of doing this in our daily clinical practice in the vast majority of centers. This is another option. Atalante trial with Tedopi vaccine has been recently published. For all of us who have been involved in this trial, we have the feeling that there is some kind of signal, although we cannot say who are the patients who are getting this benefit. Well, the trial was positive for this population, patients with immunosecondary resistance in sequential approach, positive in terms of OS and in terms of PFS, and also positive because the vaccine is really very well tolerated compared to docetaxel. There is a phase 2 randomized trial, the COMBITED. Dr. Capuzzo is the PI of this trial. In previously treated population, testing the combination of Tedopi docetaxel versus Tedopi nivolumab after failure to conventional first-line treatment. And also, thinking about the role of the modulation of this new approach with T-cell therapies, we have TILs. This is, again, a very nice proof of concept. The number of patients, again, is very small. Patients who progress after conventional treatment, nivolumab plus TILs, well, this is very nice, but again, a small number of patients, and again, I don't think that this is something that today can be done in all centers, because it requires, it's a process, a difficult process and complicated process. Finally, the TCR, this is very, very early, TCR strategies, and why not CAR-T? A couple of weeks ago, we have a meeting in Madrid. Dr. De Castro had the opportunity to organize that meeting, and I think all of us agree that we have a wonderful talk given by a a pediatrician. No? Yeah. He is an international expert in the field of T-cell strategies in hematological malignancies, and he gave us a wonderful talk regarding the potential role of CAR-T. And it's amazing what are they doing in the hematological field. Why not? We should think that we can apply all this knowledge in the field of solid tumors. Why not in the field of lung cancer? Well, as I mentioned, this is for Dr. Capuzzo. I don't give my opinion about these agents because it's the topic for Dr. Capuzzo. So the last couple of slides I want to share with you are related to how are we doing things. And when I say we, it's we as physicians, we as pharmaceutical companies, all of us. We have so many trials ongoing. We receive so many feasibilities, so many options. It's difficult to say that some of these options with this background are going to be successful. So probably we need to move forward and try to do the trials Dr. Naidu showed us before. Trials probably more academic that requires a collaborative efforts between academic labs, clinical departments, and also pharmaceutical companies. Trials trying to get answers. Why patients progress? Why do patients do not progress? Try to understand much better the combinations we offer to every specific patient that we are treating in the second-line setting. So this is just one of those examples. And as I mentioned, this is for me a very nice way to move forward. So this is a very complicated unmet need scenario. We have, as Dr. Naidu mentioned, limited knowledge, biological, also clinical knowledge regarding primary and acquired resistance. It's difficult to identify patients who can benefit from these multiple combinations I have summarized in the last 15 minutes. And I truly believe that many of these agents are active, but probably we are losing the development of these agents because we cannot identify the signal in the trials we have seen. We have multiple phase 2 trials ongoing, and there is an excess of Me-Too agents. And as I mentioned before, I think that we need to convince ourselves that translational academic research is the best way to move forward. I don't know if you are aware, today is February 2nd. Es el Día de la Marmota. Esta es la sensación que yo tuve, this is the feeling I have preparing this talk. So we are here in Gran Canaria, and if I have to predict that the winter is finishing, I would say yes. We are, yes, no doubts. And this is my place. This is not like that today, okay? This is summertime. So it's more difficult for me to predict when spring is starting in my place. But anyway, I think we are in the right direction. Thanks a lot.
Yeah. Thank you so much, Caro. I think we join Dr. Liu and Dr. Rodriguez to the panel discussion. Perhaps some questions. After this nice presentation, I think we have some questions. I don't know if the audience has any questions before. Perhaps, Jaruska, you have mentioned that perhaps you have to design new clinical trial in second line, considering in the stratification, the potential mechanism of resistance in front line. What do you think about that? Because nobody does.
I think that's sort of in an ideal world, and I guess as Rosaria mentioned, the Hudson trial, did try to do that and has tried to do that. I think that would be the ideal scenario. I think it was mentioned earlier as well that we could theoretically try to integrate these mechanisms, come up with a signature that then allows us to select the appropriate patient for the appropriate mechanism of resistance. I think our technologies are evolving and haven't got to a point where they are fast or efficient enough for us to do that yet. But I think that's certainly the holy grail of where we would go. And right now, this could be one of the reasons why all the trials appear to be negative.
And perhaps related to this point, is it logical to continue with IO after IO progressive disease in all the scenarios, or in which scenarios and which partner? Because this is the normal study designs in second line that we have.
Yeah, I'm interested to hear what the rest of the panel think, but I think that really that was a hangover from the original protocols and how they were written, this phenomenon of pseudoprogression that is more common in patients with melanoma, but certainly in lung cancer that has been proved to be a less common phenomenon. So I think treating beyond progression is certainly not something I do routinely. There is data for re-challenge in certain scenarios, but we know that even at the time of re-challenge, our IO responses might be a bit abbreviated. So I don't know, Rosario, do you have an opinion on that?
No, I am fully agree with you. I think that we have different options and different clinical scenarios, and since we don't have a magic bullet in this setting, I fully agree with your presentation. I think we need to consider every patient. I think the local treatment has a role in some patients. For me, an early progressor, I really don't feel offering a trial continuing immunotherapy plus whatever. I prefer to offer a trial with another mechanism like an ADC or whatever. But, you know, I think if you have potential options in different trials, you also need to take into account the patient you have. Is a patient who has progressed after 2 years on immunotherapy, is very symptomatic, is not symptomatic, what I can get from local therapy. So, you know, I don't usually do treatment beyond progression. It's not something that I...
Any question?
I think that this is such a hard space for drug development, and I think that all of us in phase 1 programs have seen all these OX40 agonists and other checkpoints come and go, adenosine, similar way, and you just outlined beautifully how complex it is. And so how arrogant for us to think that we could just give one thing to everybody and have it work. But I also think that if you look at a study like Hudson, which on paper looks really nice, I'm not involved in the trial, but if you wait till someone progresses, do a biopsy, send that biopsy centrally, try to uncover the mechanism and direct them to a study, it takes too long, people get too sick.
Yeah.
You're going to deal with such a selective population that is not going to be representative of anything we see in clinic. And I really just think it's an experiment in futility. I think that waiting till progression is too late. And especially since we sometimes hang on with IO a little too long, that if you wait until that long, I don't think that anything's going to come with it. I think we need to move things up earlier, and if there's signs dynamically early that after 2 months, hey, I know that things seem stable, but this is not going to be a long-term survivor, I think we need to pivot earlier. So I think waiting until progression, I think that's a flawed premise, and I think it's time to change that.
Yeah, or have something in between, right? That when you do this scheduling, that we have something to stop the cancer from growing. Well, but we don't have it, but that's what could help.
But I think we need also to combine with blood, you know, with liquid biopsy or something like that, trying to find not only in the tissue, but also in the blood, because it's a complex process. It's an IO, because you can take a biopsy in a piece of tumor, and maybe it doesn't represent exactly which one is the mechanism resistant. But on the other hand, the other fact I want to share with Joaquin is, because in second line, it's so heterogeneous right now, because there is a lot of a wide range of possibility. Those patients, primary resistant, secondary resistant, but it's not the same who progress after 1 year to receive 4 cycles of platinum-based chemotherapy and then immunotherapy, and then after 1 year, they progress. It's not the same to the patient who progress after just 3 cycles.
Exactly, yeah.
And it's not the same of the patient who progress after 2 years of immunotherapy. And we are retreating patients with platinum-based chemotherapy in lung cancer. At least we are doing. It was impossible 5 years ago. And right now, it's changing. But I love to see the slide that you present with the checkmate 9A. It's amazing. Even in clinical trial with a very high selected population, it was just 45% of patients receiving second line. Still a small group of patients. So we are losing a lot of patients. I don't know what you think about that.
No, but I think that's our problem, right? The problem is that we don't have, just like Stephen said, we don't have the real clinically, we cannot identify who are those patients who are really rapidly going to deteriorate and where everything is beyond repair, because we are probably behind that already. It's not the CT scan, there's something more happening which just switches it, and then it's not purely tumor growth, but it's a total collapse of the whole system, right? We all have those patients, and it's 1 week, and then 3 weeks later you get a card saying that he died, and then you're surprised. But that's something we missed, but that is really where we need to have more insights in how clinically we can identify those patients. And but saying this is not having a solution, and that's what the problem is.
That's why we need a mixed protocol, not only tissue, but only. What do you think?
Yeah, absolutely.
Questions from the floor? And I have a question for Joachim. This is about your best scenario to consider a challenge with immunotherapy in your clinical practice, if you consider this option.
Yeah, so what we know from the data is that those patients who let me first start. Those patients who stop treatment because they ended the maximum cycles of treatment, it's a way.
2 years.
Yeah, the 2 years, and then it's the longer the interval, potentially the better they will respond again, because then potentially they will get the same mechanism. The other thing is, of course, re-challenge in patients who got toxicity, and I think we didn't touch on this, but the thing is that we know that we have to interrupt treatment in patients on toxicity. Some of them will keep in remission, and others you can also restart the treatment, and it's also depending on the time interval whether you can restart it, whether you need to restart it, and then you still can see responses. So I think this is a group where we also have to learn and gather clinical data from real world, because that can help us to make decisions on this.
And your experience with re-challenge is satisfactory, or?
Yeah, I think I am, but that's also due to the fact that we don't have another option. So what I'm trying to say is that when I have a patient in a good clinical condition, I think the time has passed, and then I thought, well, I can start docetaxel. I can first try to do a re-challenge with an IO, sometimes, like I was saying, sometimes in combination with platinum chemo again, and then look what's happening, and then still can switch to docetaxel, but ultimately also lose patients.
Joaquin, any room for anti-angiogenics at the moment?
Yeah, so I think that's, I don't know whether it's covered, but there is some kind of, in my view, revival of anti-angiogenic in combining it with PD-1, and also after progression on PD-1, adding them to it, and then we see things happening, and just like you told in your talk, that maybe there's something happening, and then with the TMA that you can reinvigorate that the cells the immune cells can enter into the tumor, for instance, or there's immune activation due to VEGF blockade.
Last question. Do you have any questions? Perhaps Jaruska and Charo, rapid progressor exists after using chemotherapy in frontline? Do you think so or not?
Hyperprogression.
Rapid progressors.
I think I have seen it twice, where I had a patient who had what I thought was just normal lung cancer progressing, but not acutely symptomatic, and then rapid development of pleural effusions, pericardial effusions, ascites, where there was just a change in the trajectory of the tumor. But I think that this is hotly debated in the immunology field as to whether this is a true biological phenomenon or not, but I think I have seen it, but extremely rarely.
Yeah, I fully agree. I don't think that we have this rate of rapid progression that we can find in some papers. In my practice, I don't have that feeling, no.
Especially when you use chemotherapy.
But maybe dependent on the start of treatment, because I think when you start on chemo IO, it's different than you have monotherapy.
Because I thought that before starting, before using chemotherapy or not using chemotherapy should be different scenario.
Yeah, so we've done some research. We've done research looking, for instance, that PD-1 inhibitors can also increase the number of regulatory T cells, and we heard this morning what the effect of those regulatory T cells can, and then you can really exaggerate tumor growth, but potentially you can prohibit that by giving chemotherapy. Right. So that's why I think we see it less now when we give combination.
Yes, but I have to recognize that at the beginning, when I heard the first time hyperpreparation, I saw Well, it could be the biology of the tumor.
Yes, that's right.
But I have to say that in one or two cases, I have been on doubt, and I do believe that in some cases, maybe, the immunological effect is so complex. We see that with interleukin, when you say, in some moment you are pushing, and in other moment you are taking out the brake. I don't know, but maybe in some case we can produce an hyperprotection. And I do believe it's rare, really, but I do believe that it exists. I don't know.
Okay, thank you so much.
Clear, but
If you want to continue with the next...
Ernest, the last question.
Do you consider in your clinical practice biopsies when patients are progressing early or not so early? But because that could be, I know that we do that for clinical trials, but in some patients maybe we could also change our approach. There are rare cases of histologic transformation or samples that have been sequenced and maybe the tumor representation is low and maybe repeating NGS, or do you think it doesn't make a lot of sense out of a clinical trial space?
No, I think it makes sense. I do not do it routinely for all my patients, but for example, if I want to do rechallenge after a period of time, after the patient finishes the treatment, I want to do rechallenge, I usually try to figure out what is going on, or if the clinical evolution is something that I don't expect, trying to rule out other causes like a transformation to small cell. Yes, sometimes I think it's useful, or at least we think we can get some information, but it's not a common, I do not do it in the vast majority of my patients.
I think they're an important part of trials, but I don't do it. Because I feel like when you're progressing, that clock is ticking. I feel like I don't have a lot of confidence that my next line of treatment is going to work, so I want to get going quickly so I have a little time to maybe try something else.
the problem is, what are you looking for? Because I have been upset with when we do rebiopsy and then trying to find, for instance, TIM3, high level of TIM3 in rebiopsy in patients with progressive IO, and then when we treat them with anti-TIGIT, has been negative. The result was a very low response rate, at least with some of the TIGIT, some of anti-TIM right now in the research. I don't know, the problem is, what are you going to look for?
We had, for example, a couple of cases of histologic transformation to small cell in patients treated with, it's less common, but that happens in patients that they progress with lymph nodes in a moment that you don't expect. And that is, we were thinking that it was very rare, but then we checked in PubMed and there were some cases, or what we commented before, that maybe patients that they are a little bit on the limit of the NGS maybe was conducted with only 10% purity of tumor purity, and then we could consider that we have false positive of that NGS, and that could be, but it's true that it's not really feasible in many patients.
Yeah. Okay, we move on to the second part of the presentations. Thank you so much. Thank you. I have the honor to present Dr. Federico Capuzzo, very well known for all of us. Is going to present the options such as CADC and potential bispecific beyond IO failure. Your turn.
Okay, thank you very much. Thank you, Rosario, Delvis, and Luis for the kind invitation. I have to say here, simply because I don't see anything. So in some way, I have to watch at least the screen. So I thank you very much for the invitation, for giving me also the opportunity of discussing about a very relevant topic, that is the ADC in the field specifically of lung cancer. This is my disclosure. And this is the outline I'll follow. So I'll discuss a little bit about mechanism of action and how this class of agent works in a different context. Already Marina anticipated in her lecture many of the data, the clinical data, so I want to try to put these agents in the context in which they are working, and I'll give you also a very quick data. I'll present you some quick data on a new class of agents that are the bispecific ADC. So how they work? This is, of course, the first question. So apparently, these agents are very simple agents, apparently, because this is just a monoclonal antibody that is linked to a chemotherapeutic agent, and by targeting a specific receptor in the tumor cell, they can deliver the chemotherapeutic agent directly inside of the tumor cell. And this is able to induce the cell apoptosis, so the cell is destroyed, and also we have the delivery of the chemotherapeutic agent, and therefore an effect on the other tumor cell that maybe cannot express the target of the drug, and this is what we call the bystander effect. So if we consider ADC with this very simple mechanism, of course, this is just a new chemotherapy, a target chemotherapy, but probably the mechanism of action of this agent is much more complex, because sometimes this agent interferes with a receptor that is a driver. So in this case, the ADC works as a target therapy. And also by releasing antigens, clearly we have an immunological effect. And therefore, we also have an involvement of the immune system. And this is also one of the reasons why many clinical trials are currently exploring the possibility of combining also these agents together with chemotherapy. So this is just a very simplistic, I can say, overview of some, at least, of the agent. We have a lot of agents under investigation in non-small cell lung cancer. Here, I'm just presenting this agent in this way, just for showing you that we have some agents that are targeting some receptors that play in some way a role as a driver. This is the case, for example, for HER2, in some context also for HER3 or for MET. And then we have also other agents that are targeting some receptors that are not really a driver, and this is the case of TROP2. The classical example on how these agents could work differently according to the context is represented by trastuzumab deruxtecan. Trastuzumab deruxtecan is a monoclonal antibody against HER2 that is linked to a chemotherapeutic agent and has been tested in a clinical trial including two different cohorts of patients. One cohort of patients were patients HER2 mutant, so the classical group of patients oncogene addicted, and the other cohort of patients were those patients just overexpressing HER2. So in this case, the role of HER2 was not as a driver of the tumor growth. When we look at the results, clearly the results are totally different. When we look at the cohort of patients in which HER2 was a driver, so in the HER2 mutant, response rate was more than 50%, also with a very long duration of response, progression-free survival, and a potential positive effect in terms of overall survival. But when we look to the other group of patients, so those patients in which HER2 was just used by the drug for vehiculating the chemotherapeutic agent inside of the tumor cell, so in the group of patients HER2 overexpressing, response rate was between 20 and 25%, so was clearly lower than in the different contexts, also with shorter duration of response and shorter progression-free survival. This is not only something that we are observing only with this agent, because we are replicating this data with all the other agents, and I show you the data, for example, with patritumab deruxtecan. Again, patritumab deruxtecan is against HER3, and when we look at the data, you can see that in the group of patients, EGFR mutant, osimertinib resistant, this is a context in which HER3 play a role, I can say, as a driver, simply because it represents the major partner for dimerization with MET, that is one of the most relevant mechanisms of resistance to osimertinib. Well, in this context, the response rate approached 40%, while in the other group of patients in which in the non-oncogene addicted population, response rate again was around 25%. During the ESMO last year, so a few months ago, were presented also data from a very nice trial that was the Tropion Lung 05 trial, specifically assessing the efficacy of datopotamab deruxtecan in patients oncogene addicted. When we look at the general characteristics of the patients, you can see here that the vast majority of patients included in this study were patients with EGFR mutations. We had also some patients, approximately 25%, harboring ALK rearrangement or even other molecular events. And again, when we look at the results, response rate in the group of patients EGFR mutant was particularly high. It's interesting that the response in the group of ALK positive was probably lower than expected, suggesting at least that not all drivers could influence the activity and the sensitivity of these agents. So with this perspective, considering this potential mechanism of action, considering that these agents could be more sensitive, more effective in the group of patients with molecular events, are not surprising at all the data from the Tropion Lung 01 trial that were presented this year, again during the ESMO meeting. That was a phase 3 trial comparing datopotamab deruxtecan versus docetaxel in second-line setting in patients with non-small cell lung cancer. This trial was designed for addressing a very relevant clinical need, because we know that second-line therapies are not really effective in non-small cell lung cancer, because we need more effective agents, because all the companies are working for replacing docetaxel, because we need also to reduce toxicity for the patients. Was this trial able to reach all of these endpoints? Unfortunately, no, because when we look at the primary endpoints, this trial had two co-primary endpoints, progression-free survival and overall survival. The primary endpoint of overall survival was met, so there is a significant improvement for progression-free survival for those patients receiving datopotamab, but the other co-primary endpoint of overall survival was not reached. It's also important to look to the efficacy of these agents according to the different subgroup of patients. And what we can see here is that, and this is not a surprise considering what we said before, that the efficacy of this agent was higher in the group of patients with known squamous histology. That is exactly the group of patients in which we can detect molecular events. And in fact, the activity in the group of patients harboring molecular event was particularly remarkable. The hazard ratio was 0.38 in terms of progression-free survival, specifically for this subgroup of patients. The other important point is if we can really if we can really avoid some toxicity to our patients. Well, this is a very important issue. I was impressed at how Marina was so strong in the conclusion, because I was more soft, I can say. But maybe this is something that really we are thinking, because we expected from these agents a very good toxicity profile, but this is not what we are observing, unfortunately. This is the experience that we have as investigators. This is what the data are telling us. These are the toxicity profile of datopotamab or trastuzumab deruxtecan. With these agents, we still have relevant toxicities in terms of hematological toxicity, in terms of alopecia, in terms of gastrointestinal toxicity, particularly mucositis. So we have a lot of events that clearly are relevant in clinical practice. This is agents that, at the beginning at least, the company planned to develop in a second-line setting, so in a group of patients that are clearly frail. So this agent is difficult to offer this class of agents in a frail population. Of course, the question is, if the ADC are so specific, why we have toxicity? So clearly, we have toxicity because the target could be present even in the normal cell, but also is important, of course, the type of the linker that we have. We have some cleavable linker that, with a cleavable linker, of course, is much more easy that the drug could be released, is more potent, but also clearly there is the risk that the release of the drug is also outside of the tumor cell, and therefore this is responsible for toxicity. Or we have a non-cleavable linker, and in this case, of course, there is the risk that we are reducing dramatically the efficacy of the drug. And of course, the payload is extremely relevant for explaining the difference in terms of toxicity that we can observe by using these agents. Moving to the new bispecific ADC, this is a new class of agent. The preliminary data we have are very exciting in terms of efficacy, and I show you as an example one of the agents that was presented this year during the ESMO meeting. This is a bispecific anti-EGFR HER3 agent. And this agent was specifically tested in patients pretreated with non-small cell lung cancer, oncogene addicted and non-oncogene addicted. When we look at the overall result in the whole population, the response rate was more than 50%, so really impressive activity. Also remarkable activity in presence of brain metastasis. Now we have data from different ADC showing that these agents, even presented during the ESMO meeting, showing that these agents are potentially effective in presence of brain metastasis. But again, we have some limitations. When we look at the results, at the efficacy was clearly higher, specifically in the group of patients harboring EGFR mutations. And the other important limitation, again, was represented by toxicity, particularly hematological toxicity that was not negligible. So in conclusion, we can say that certainly ADC are showing efficacy in non-small cell lung cancer. We have a signal of efficacy of these agents with datopotamab that is superior to docetaxel, at least in terms of progression-free survival and in some subgroup of patients. But the efficacy clearly is higher in the group of patients harboring mutations, harboring molecular events, but the safety of this agent represents a critical point. It represents a critical point because in second line it's difficult to use this agent in a frail population because we need to consider the risk of toxicity when we are using in frontline setting in combination with other agents. There are many clinical trials testing this agent together with immunotherapy and also together with chemotherapy. And also, I would like to recommend to the company also to pay attention when they are using this agent in early stage disease, particularly in the neoadjuvant setting, because the excess in toxicity could preclude to these agents, even if they are very effective, to reach a positive result. And of course, the bispecific agent represents a new class of agent, very promising, but again, toxicity is one of the major concerns that we have. Thank you very much.
Yes, thank you. The next speaker is Yair Bar from Institute of Oncology, Sheba Medical Center, Israel. And the title of his presentation is Still a Place for Targeting TAM Receptors After IO Failure.
Hi, good afternoon. Thank you for everybody staying this late. I want to thank the organizers for inviting me to give this talk in this fantastic place and in this great meeting. This is my title, Still a Place for Targeting TAM Receptors After Immunotherapy Failure. That's what they gave me. I changed it a bit and added a question mark at the end of this sentence. And you will see why in a minute. So these are my disclosures. And what are the TAM kinases? So TAM does not stand here for tumor-associated macrophages, but rather for 3 tyrosine receptor kinases, which are very similar and are commonly investigated together. And you see the names, the short names, Tyro3, Excel, and MER. And it took a while to understand exactly what they're doing because of their overlapping activities. So only in triple knockout mice, you could understand their activity. So these mice have immune hyperactivation and autoimmune diseases. And if you look at the cellular level, you see this is mediated by mostly macrophages and dendritic cells proliferation. And at the cellular level, you realize that this is another checkpoint, basically, which is active mostly in antigen-presenting cells. So an antigen-presenting cell would be activated as an innate immune cell by TLR receptors or other signals. And that would, in turn, activates the expression of the TAM receptor kinases and would downregulate the activity of these cells. And this is an example from a cellular model. And you see when AXL is knocked off, you see dendritic cells binding the T cells. That's the red and the green dots, the cells, presumably representing antigen presentation to the T cells. When AXL is on, this does not occur. So again, this is another type of immune checkpoint. And what happens in cancer? So these kinases are very rarely mutated in cancer. So this is certainly not a typical oncogene. However, they are activated by overexpression of the kinases themselves and by the presence of their ligands. And in general, they are activated by stress signals, which is common in cancer, in the microenvironment. And if you look at the the molecules involved, you see here the 3 kinases that I've mentioned. AXL, the left one, is the one we'll be focusing on. They share partly the ligands. The GAS6 is the major ligand for AXL, and PROS1 is the major ligand for the other 2. And the signaling pathway for all 3 converges on cell proliferation and survival. Regarding AXL, it's mostly the RAS signaling pathway. And again, we'll be talking mostly about AXL now. Looking at the tumor microenvironment, you see that we can see that AXL activation has both a cell autonomous effect of EMT and cell proliferation and survival on the cancer cells, and an effect on the microenvironment of immune downregulation, mostly through the macrophages, the tumor-associated macrophages, and through dendritic cells. In both cases, causing downregulation and inhibition of the T cells. So apparently, seems like a perfect target as an adjunct treatment for cancer. And if you look at the non-small cell lung cancer, you see that AXL is present, is found in a large majority of the tumors, both in the tumor cells and or in the immune cells. And these results come from STK mutated or non-STK mutated non-small cell lung cancer. And we'll see in a minute why I'm mentioning this. And this is more data from large sets of molecular analysis of non-small cell lung cancer patients. And you see that AXL, in general, is correlated with poor outcome and also with resistance to PD-1 inhibitors. And AXL expression is correlated with resistance to various drugs. So there's very nice, very good data about correlation with resistance to EGFR inhibitors. That's the data you have on the left, and there's more data. I didn't have time or place to show all the data, but in several screens where you look for genes that are associated with resistance to EGFR inhibitors, AXL comes up as one of the top hits. And in the middle, you see a mouse model where if you add AXL inhibitor, you get better results in terms of EGFR inhibition. And there's an example of one of the trials that are ongoing of combining osimertinib with an AXL inhibitor. And in many other models, you see the same type of result where AXL inhibition synergizes with other drugs. So you see here a prostate cancer model on the left and a GBM model on the right. And you see AXL inhibition synergizes with various chemotherapy agents, with radiotherapy. And looking at all of the basic science data, you think that you have the perfect tool in hand. All you have to do is inhibit AXL, and all other therapies will start working fantastically, and tumor will go away. So what do we have? So there are many agents. Some were developed and some not developed for this purpose, but are also inhibiting AXL. So you see here tyrosine kinase inhibitors, the higher part of this table. You see some of the drugs that were developed specifically for AXL. So bemcentinib, we'll talk about that in a minute, and other drugs that were that inhibit also AXL, like sitravatinib and cabozantinib and sunitinib, which inhibit mostly angiogenesis, but also inhibit AXL. And besides that, there's also a decoy receptor. They are blocking antibodies. There are at least 3 different ADCs targeting AXL, considering its high expression in tumor and in lung cancer. And at least 1 CAR-T program that is targeting AXL. So a lot of activity in the field, again, based on very good preclinical data. What do we have in the clinical field? So Bergen Bio is one company that is focusing on this target. That's a partial list of the ongoing trials that's running, not only with bemcentinib. And the first trial I'll mention is the phase 1, combining bemcentinib with docetaxel as for advanced line patients. And you see here there's an apparently nice response rate of 35%. It's a very small trial. There was also significant toxicity, but there were some apparently prolonged responses, as you see here in the spider plot. Then another trial worth mentioning was presented by Enriqueta Felipe, this ESMO, and this is a phase 2 combining bemcentinib with pembro for second-line non-squamous non-small cell lung cancer, and there were 3 different cohorts here. All the responses were in cohort A, which were patients that were not previously exposed to immunotherapy. So 22% response rate for second-line pembrolizumab, basically, plus AXL inhibitor. All the other cohorts, the 2 other cohorts that were previously exposed to checkpoint inhibitors had no responses. But if you look at the bottom line of the progression-free survival and the overall survival, you see that it's better than historical control. So this there is some optimism if you're a very optimistic person, looking at these results. And one thing that is interesting in this study is this analysis comparing the patients where the tumors have a high versus low AXL expression. And you see that it is correlated with the outcome. And interestingly, there was no correlation with PD-L1 expression, but only with AXL expression. So this is one set of data which is encouraging, saying that this might be a target. The other thing is looking at the STK11 mutant patients in this study, and actually these patients had not significantly, but slightly better outcome than those without the STK11 mutation. So certainly not a worse outcome. So this is also suggesting that maybe this does have some significant effect. And actually, there is a fast track designation of bemcentinib for STK11 mutant adenocarcinoma, based on this data and probably additional data. And there's an ongoing study testing this now in the first-line treatment. I will mention also 2 other trials with this drug, one in mesothelioma. So this is a trial looking at advanced line mesothelioma after failure of platinum-based treatment. So they had here an 11% response rate to a combination of bemcentinib and pembro. And there's a lot of correlative science ongoing on the samples of these patients. So this is just another thing that we know about this drug. And there was also a very negative trial in melanoma testing it, bemcentinib, as a first-line addition either to pembro or to BRAF inhibitors, and there was no signal of efficacy at all in this study presented the last ESMO. So moving on to other drugs, just to complete the picture. So sitravatinib inhibits also the TAM receptors, and there was a phase 2 single-arm study of sitravatinib plus nivo in a combination of checkpoint inhibitor naive and resistant refractory patients, and there was a 25% response rate, leading to the SAPPHIRE trial, which was mentioned a few minutes ago, which really was a disappointment, of course. And this was testing sitravatinib plus nivo versus docetaxel, and didn't show a benefit, a significant benefit, not in survival and not in PFS. And this is basically an anti-angiogenic agent, and just reminding that lenvatinib in a very similar setup failed also in a similar type of phase 3 trial versus docetaxel. Moving on, cabozantinib, that's another drug which inhibits many kinases, but also AXL, and this also was tested in combination with atezo versus docetaxel, and did not prove any benefit in this combination. Moving on, the ADCs, so that's one ADC that's developed against AXL using PBD as the payload, which is a relatively novel one, which is interesting because there's no overlapping resistance with the chemotherapies that we're using. So hopefully we'll see some good results from that. That's a drug that's produced actually by actinomyces. If you're interested in the background of this, we'll see if that works better than other ADCs. Another ADC which is interesting is a conditionally active drug, which is dependent on acidity of the microenvironment to be activated. This also is targeting AXL, and there's a study now focusing on AXL-expressing non-small cell lung cancer. So hopefully this might lead to better results. There is, as I mentioned, AXL decoy receptors, so binding the Gas6, which is the ligand of AXL. This drug was tested in renal cell carcinoma. I'm just mentioning it to give the full picture of what we have in this field, and tested as monotherapy and in combination as a single agent. There was no responses at all, but there's ongoing analysis of baseline serum soluble AXL versus Gas6, the biomarker levels. And to conclude, targeting TAM receptors after IO failure, it's a unique checkpoint of antigen-presenting cells. There's very good preclinical basis. There are multiple agents developed of various types. However, there's no clear signal for sure in immunotherapy refractory resistant non-small cell lung cancer, as have been alluded to by the previous speakers. I think it's very unlikely that a single drug added to second-line immunotherapy will make a change, will make a dent in the resistant tumor that is developing. I think in the second line, we're fighting a a losing battle, basically, against a tumor that has already developed multiple mechanisms of resistance, and we have to change completely the way we think about this. Obviously, we need predictive markers. We need to understand better the biology, potentially in this case, expression of AXL, expression on specific cells, presence of specific cells in the tumor microenvironment. All this might be leading to better successes. And just to complete, this is a Sheba Medical Center where I work. To all our friends asking, everything is ongoing. We have patients to take care of. So the clinic is ongoing, the science is ongoing, clinical studies are ongoing. You're all welcome to visit. Thank you very much for your attention.
Thank you so much. Finally, Dr. Marco Dania from National Center for Cancer Immunotherapy in Denmark is going to address about T-cell therapy in lung cancer, lessons from melanoma.
So thank you. And thank you very much to the organizing committee for inviting, how do I change this? For inviting a melanoma doctor to speak at this great event. So many of you who are staying here so late are probably asking, what is a melanoma doctor doing here to a lung cancer conference? That is what I'm doing here. I believe I was invited here for two major reasons. And I'm going to discuss these two very briefly. Reason number one, we have conducted and concluded last year a clinical trial in melanoma where we have shown that cell therapy with TILs, or tumor-infiltrating lymphocytes, can achieve tumor regression in 50% of patients with anti-PD-1 resistant metastatic melanoma. And it was a clear benefit, at least in terms of progression-free survival, between TIL therapy and across the different groups, and TIL therapy versus ipilimumab, so an anti-CTLA-4 antibody. What I want to highlight here, that this is a trial that was fully academic, a joint collaboration between the Netherlands Cancer Institute and my institute in Denmark, Center for Cancer Immunotherapy. No commercial entity involved. What does it mean, this one? It means that we enroll the patient, we produce the treatment, and we give the treatment to the patient. We do basically everything by ourselves. The only similar situation you find here in medicine is autologous hematopoietic stem cell transplantation, where you take the patient, you make the treatment, and then you give the treatment. Reason number two that lies in this slide. Melanoma has been the front runner in the checkpoint inhibitor race in the past decade. And everything started with ipilimumab around 2011. As many analysts believe that this is going to be the decade of cell, gene, and mRNA therapies, one very likely possibility, and there are many similarities between TIL therapy and ipilimumab, could be that TIL therapy, again, therapy with tumor-infiltrating lymphocytes, is going to be the ipilimumab of the next decade. And just to say a little bit more about the stage of what we are talking about when we talk about cell therapies, we are talking about two major types of treatment modalities. One is the naturally occurring T cells. So we select cells, or we just expand the cells, we give them back to the patient, typically to the same patient. So it's an autologous kind of treatment. On the other hand, on the right-hand side, you have genetically engineered T cells. Probably many of you have already heard about this. Genetically engineered cell therapies are, for example, CAR T cells or TCR engineered therapies. So what you do is basically to give an artificial, somehow, receptor to some T cells, again, typically from autologous sources. The main difference, at least from an enrollment point of view, is that here on TIL therapy on the left, what you have to resect is a tumor, because you isolate and expand T cells from a tumor microenvironment. Remember that the T cells in a tumor microenvironment are there for a reason. That's because many of them are tumor reactive. On the other hand side, on the right, what you take typically is peripheral blood. And then you make the treatment and you give back to the patient. What I'm going to talk about in the next 10 minutes is 4 topics, and we'll take it very briefly, and also something about, start with something, how do we make these treatments? Now, I like to show this, this picture. First of all, who doesn't like to show a picture of himself young? It was over 10 years ago. But also to show that this treatment, I'm not there inside in that good manufacturing practice lab just for a chance. I'm there for a reason, and that's because I have made that treatment. It's because if I can make, probably everyone here can make it. Even Alfredo, we can make it probably. It's not rocket science. It's just taking cells, expanding them with some specific methods in some clean conditions, and they give them back to the patient, all of them. That product you see there, white, that's around 150 billion cells. So we start with few 100,000, and we end up with 150 billion cells. For those of you who play golf, that's the size of the product. So it's like a big lymph node. How do we give this? This is a one-time treatment, so once in a lifetime. It's not a 3-year treatment. It's once. We give the treatment, and that's all. But we give it preceded by lymphodepleting conditioning chemotherapy, which is given to make space to this huge amount of cells that we're going to give intravenously, and then followed by high-dose bolus IL-2 that is given to support the growth of these cells in vivo in the patient. This is the source of probably 99.9% of the adverse event of this treatment. So it's not the cells that you are giving, it's actually the other regimens that you are giving that make the toxicity. And what you do, essentially, is that you wipe out all the immune system of a patient, giving the preconditioning chemotherapy. You remove all the Tregs, all the suppressive cells that are in the body, and then you give a product that is highly enriched, as you can see from the discharge there, 46.7% of tumor-reactive cells. There were 0.07, which is nothing. It's below the detection limit, so that one is 0. So you have an immune system in the periphery that is not tumor-reactive, and you change it to something that is tumor-reactive. What you hope to see is that these cells from the blood will traffic into the tumor and then mediate tumor regression and kill the last cancer cell. So this is a potentially curative treatment. And the cells, as you can see there, even 12 months after, they persist in the blood, so they can also mediate memory, exactly as every other kind of immunotherapy. But this is once-in-a-lifetime treatment. Just briefly, to give an overview on how this treatment is made, this there at the beginning is a small tumor that is resected. You have to need something to resect. Fragment in small pieces, put in culture, then the lymphocytes there around the black dot, that is the fragment, are growing out. Then you expand them in the clusters, as you can see in that flask. Then you put them in a bag, which is just a bigger flask, and then you give them back to the patient. Now, the thing is that who's going to make this product? You can make it if you have a program like we have and like many other institutions worldwide, including the Shiba Medical Center has, or you can ship it to a company with the plane. The company is going to make the product, and then the company is shipping back the product frozen to you, and then you give back to the patient. So it's a bit more complex than just having a vial of anti-PD-1 in the shelf. You just need some water and calculate per kilos, and you give to the patient. It's a bit more complex, but it's not rocket science. It's doable. And that's, again, the product that we end up with. There are some clinical challenges here. But first, I want to show not the challenges, but what we can achieve. This is a spider plot. I'm Italian, I like to call this spaghetti plot. What we see here is that the regression is fast and deep, and we have never seen pseudo-progression with this kind of treatment. So when we give the bunch of cells, either they go in the tumor and they kill everything, or they do nothing. The side effects are significant. Grade 3/4 adverse event is 100%. But that's a one-time treatment. all the side effects are predictable and happens within the first 3 weeks of the treatment. So what do? You admit the patient for a couple of weeks, 2 or 3 weeks to the hospital, and then you manage the side effects, typically hematological side effects because of the chemotherapy or side effects related to the IL-2. And I'm not sure how many of you have used the high-dose bolus IL-2 here in this audience. But probably there are some that have used, and they know what are the challenges. But the challenges is mainly they need very fit patients, because IL-2 is a harsh treatment. And if you don't give it right, then you end up with a patient in the intensive care unit. That's not a treatment for everybody. We estimate that in melanoma, in second line, post-PD-1, post-progression to anti-PD-1, around 20% of patients can be candidates to this treatment. Especially, I would like to highlight the optimal organ function that you find basically in every clinical trial. But here, for T-cell therapy, especially for IL-2, optimal organ function is really very good cardiovascular function. People like Alfredo and I, maybe we are out here, but you need to train and you need to have patients that are fit. So I'm joking, maybe I'm candidate probably, but still, you need to perhaps run at 6 o'clock in the morning. So good for the cardiovascular activity. So let's switch gear to the lung cancer. Does it work in lung cancer? Has it been tested in lung cancer? There is some preclinical evidence, first of all, relatively new of the past 5 years, that you can actually make tumor-reactive, tumor-infiltrating lymphocytes from lung cancer specimens. It's something relatively new. And we start seeing the first clinical trial with some results. For example, this trial that has been shown briefly in one of the previous presentations, it shows that this is a complex scheme. They gave nivolumab for a couple of months. Then patient who did not progress went on to get T-cell therapy, and then they got nivolumab for 1 year. What I had seen in the patient that were progressing on nivolumab, when they got T-cell therapy, some of them, 3 out of 13, got objective responses, including 2 complete responses, durable at 1.5 years. But again, they got the treatment only once. So it's a very important thing, I think, that it lasts. There are many other trials, and now that we have shown preliminary evidence, also in the past year, many companies have jumped into this kind of treatment. For example, Iovance. Perhaps many of you, or some of you, are involved in these trials. This is the cohort 3B of the trial IOV-COM 2.2. What they did is that they have screened 64 patients, but in the end, they end up treating 28. So in this kind of treatment, because of all the reasons I've mentioned you, including the manufacturing time, in this case, I think it was around 22 days, some patients drop out. So it's not for everybody. There is dropout, and then you end up treating fewer patients, those that you enroll. What was important here were all anti-PD-1 or anti-PD-L1 experienced, mixed PD-L1 expression, and they saw 6 out of the 28, which in reality evaluable is 24, so 6 out of 24 responders, including durable responses, exactly as we have seen in melanoma. And in melanoma, we saw around 20% durable complete responses. Again, other trial in the same post-IO setting in non-small cell lung cancer, but there is no disclosed results yet. I wanted also to highlight that these, both in lung cancer and in melanoma, start being tested as a first line in combination with anti-PD-1. And this is a trial where 19 patients were treated in combination with anti-PD-1, that's the schedule there, and then 8 out of 19 responses. But again, selected patients, it's not for everybody. To conclude, I'll take the last topic. It's new advancements. Now, all here have heard about neoantigens and what's the importance of neoantigens. What you can do is that when you have a product of T cells from the microenvironment, some of the T cells will be specific for neoantigens, some will be specific for shared antigens, some will be specific for viruses or something that has nothing to do with the tumor. What you can do with new technologies like sequencing and selection of cells is to select only the neoantigen-specific cells, which are believed to be the best killers. What you can also do with new knowledge that we have today, where clonal neoantigens, so antigens that are in all the trunk of the tumor, so expressed by all tumor cells, could be more important, is to select clonal neoantigen T cells. And there is a company that is doing this, and is doing a trial where they give low-dose lymphodepletion and low-dose IL-2, because they believe that the clonal neoantigen T cells are more potent. In this case, you can have more candidates, because you don't need to have these very, very fit patients. But again, a similar strategy has been tested in breast cancer. Out of 31 patients screened, 6 ended up being treated. Yes, 3 out of 6 got responses, but still, many patients enrolled, few treated. To conclude, this is a treatment with tumor-infiltrating lymphocytes that has shown efficacy in melanoma, and it's close to the approval. 20% or more responses in post-IO non-small cell lung cancer. You have some new advancement in TIL 2.0, new kind of tumor-infiltrating lymphocytes. But then there is still important challenges. First of all, patient selection is not for everybody. Number 2, you need the cell therapy expertise to administer, especially for the IL-2, but also the manufacturing, depending on whether you want to have your own program or you want to rely on someone else, like companies, doing it. And then the huge question, costs. I'll just leave this, perhaps, to the discussion. Thank you very much for your attention.
Thank you. Yes, we'll open the next panel discussion. Come here, please.
Soy Sergio Vázquez, and Steven Liu.
Gracias a ti.
Javier de Castro
corriendo.
has to leave. And now with Elvis, sharing the chat.
Fantastic.
Haas wasn't able to make it, so I'm gonna take his place. I'll do my best to sound intelligent.
I have to take the place of Javier de Castro also.
Yes. I have a question for Federico. This is about the data that you mentioned about toxicity of ADCs in clinical trials. But do you think that this toxicity could be assumed in clinical practice for the future, near future, perhaps?
Well,
what do you think?
Of course, generally in clinical trials, we have selected patients. So clearly, in clinical practice, I expect that if there isn't a learning curve that is very high and very quick, there is a risk that we can also replicate these adverse events in the general population. I know that the companies are working a lot in prevention of all of these adverse events, particularly gastrointestinal and the mucositis. There is a huge interest. In our institution, we are also working in a project on microRNA that could potentially predict sensitivity to, development of these adverse events. But I think that in general, the problem of toxicity management with any agent, and specifically with ADC, is something that we need absolutely to consider. This is, I repeat what I said during my presentation. In second line, we need agents that are less toxic than docetaxel. And this is not what we are perceiving when we look at the data from the clinical trials, and also this is the general opinion of many investigators I had the opportunity to discuss. The the companies also are developing a very aggressive strategies for frontline setting. And again, some trials are using a combination together with chemotherapy, so another agent together with immunotherapy. That is a very aggressive strategy with the risk of toxicity, even if in frontline definitely is much better, is a better context, because generally the patients are more fit and therefore are more able to tolerate the treatment. And the big issue, in my opinion, is the usage, particularly in the early stage. So the risk that some patients, because of toxicity, cannot go to the surgery, for example, so they cannot have access to a treatment with curative intent. This is a big risk that should be considered in clinical trials.
I have a question to you. It's about the patient profile. You have defined very well, no? Fit patients, oncogene addiction. I don't know if there are another clinical characteristics as toxicity to first-line treatment, as pneumonitis, for example. And also, if you can explain us the possible future of the ADC targets of a possible biomarker in the patient selection.
Well, the big issue certainly is that we are not able to predict who are patients really sensitive to these agents. At the present, we know that in the context of oncogene addiction, certainly we have the highest efficacy. But I want to consider the agent for which we have the best data so far, that is trastuzumab deruxtecan. With trastuzumab deruxtecan, we have a fantastic data in HER2 mutant population. But again, response is in 50% of the patients. So we have half of the patients not responding to the treatment. So it's important to refine also who are patients more sensitive to this agent, even in a context in which the efficacy is already high. In the other patients, certainly we need to look at the different biomarkers. So the companies generally, they were looking to the expression of the receptor. That is a logical approach, but the correlation with the expression was not optimal at all. My personal opinion, this is absolutely not supported by the data, is that probably we need to consider additional biomarker, and specifically the group of biomarkers for which there is no interest at the present, or the interest is very limited, is represented by copy number. This is something that I started with my career, because I started my career with copy number, with fish testing, so with amplification. But I think that this is something that is completely forgotten, and even if the amplification are included in the NGS panel, NGS probably is not the best method for assessing amplifications.
Okay.
Hi. Okay. So, oh, sorry. Hello. Joe first.
Thank you. Yes, I had a question for Marco regarding TIL therapy. So something that we've seen with a collaborator in the lab is that during TIL expansion, the repertoire changes significantly. And actually, in some cases, the repertoire changes to a point where T cells are selected for those recognizing viral antigens instead of neoantigens or tumor-associated antigens. So my question is, do you check for the repertoire before giving the TIL product to the patient, or do you think this is not needed?
So the question is, do we do anything to avoid skewing for the repertoire from tumor-specific to a virus-specific? So this is not feasible in a real-life clinical setting, so we don't do that. But this depends on will your final product be so harmed by the expansion that is not anymore useful for that. We don't check that, but it's possible that for some patients that's skewing too much to the virus-specific.
But in the trial or in your regular practice, you do not check for the repertoire before infusing the patient, right?
No, the quality control, at least in this phase 3 trials have shown, is not related to the potency, if you can call like that, of the specific product.
Luis.
My question is related to the ADCs and biomarkers. Actually, I'm really surprised that we are only looking at the antigen end in the tumor cell, so where the receptor is binding, but not biomarker related to the payload. And looking honestly, we see that the antigen expression is not relevant. As you said, sometimes it's important that in some tumor, they are oncogene addicted. The reason likely is not because of the biological function on the protein, but because those tumors specifically, they do have a higher turnover, and then they internalize more payload. And indeed, we know that those tumors that are oncogene addicted typically are genomically more simple, and they just respond better to chemotherapy, right? So wow. So my question is, I'm a bit strange that all the effort is there. And another different question is, you talk about ADCs and biospecifics, which are interesting agents, unfortunately not very successful so far. I have to admit, on my view, some responses in the range of re-challenge only, and being like pragmatic. Still, we have another type of biospecific, which are the T-cell engagers. And we have seen that in the most difficult tumor to treat, which is small cell lung cancer, those agents have proven to work. If something is working in a small cell lung cancer, immunotherapy, in a highly proliferative tumor, in a very cold tumor, that means we have to find the way those agents are going to work elsewhere. We just need the right antigen, right? This is just to be a bit provocative.
No, but I totally agree. I mean, I think that we are just at the beginning of immunotherapy, because we need to consider that a few years ago, when we started with immunotherapy, with the first data with nivolumab versus docetaxel, during conference, at least in Italy, people said, oh my God, I'm not so convinced to shift to nivolumab because docetaxel is a good drug. So that was the idea a few years ago. So clearly we are just at the beginning. We need to learn more about immunotherapy, mechanism of action, the role of a different receptor that we have. Now there is all the studies with the anti-TIGIT. We heard all the presentations today. But I think that certainly we need more potent agents. The engager could be certainly a very provocative class of agent. The data that we have, for example, in small cell lung cancer are really, really exciting. Going back to the question of chemotherapy efficacy, payload, etc., we know since probably the discovery of EGFR mutations that EGFR mutants are more sensitive to chemotherapy. So this is not absolutely a surprise in general. And of course, I totally agree that the payload is important, because at the end, we are just using mainly topoisomerase inhibitors, so old agents, and we are not giving something that is really innovative in terms of chemotherapy. So I agree that probably we should also think about the payload.
Tomeu?
My question is also to Federico. One of the differential characteristics of ADC is the bystander phenomenon. So do you think that in order to predict the real effect of bystander, the linker is more important than the target, or do you think we have possibilities to improve this and to predict this effect, this specific effect?
Well, based on the mechanism of action, both are relevant, in my opinion, because first of all, we need to reach the target, and then we need to obtain the release of the drug. So certainly the two components are important. We need to reach the target, and then we need a linker that is enough cleavable to allowing a very rapid distribution of the payload.
Jaruska.
I go back to Marco for a question about the T-cell therapy. So in Ben Creelan's study in lung cancer, the proportion of patients with lung cancer that responded to TIL actually an important proportion of them had EGFR mutant lung cancer, which traditionally doesn't respond to immunotherapeutic approaches. So I was just wondering, from the melanoma experience, do you notice that the BRAF mutant melanomas respond more to TIL, or is there a hypothesis that oncogene addiction matters with regard to response to TIL, or any particular clinical characteristics that could help us understand who might respond to that type of approach?
Yeah, so we do have some ideas of biomarkers, but so far nothing has been conclusive. Regarding the mutations, we haven't seen anything like BRAF positive or negative respond better or worse than others. You consider that all patients were PD-L1 or PD-L1 resistant. What does it mean? It means essentially that the mechanisms of resistance are not necessarily the same. If you have a beta-2M loss, complete loss, of course you're not going to respond neither to T-cell therapy or to anti-PD-1. You're not going to respond to ipilimumab neither. So some mechanisms probably are overlapping. But the major core of the mechanisms probably are not the same.
So another question to Marco. Marco, you showed the big attrition in the TIL trials of the number of patients screened to the number of patients you're able to generate and give product to. I guess there are two questions. One, is there something intrinsically different about a tumor that will be able to produce TILs that makes that patient perhaps more likely to benefit because there's something intrinsically different about the tumor? And the second is a practical question. For someone with metastatic lung cancer, what is the sort of typical volume of tissue that you need, and where would you is there a preference in where to do the surgery to get the tissue from?
Yeah. So the site of metastasectomy so far has not been seen as a factor influencing responses or capacity to generate TILs, yes or no. In lung cancer, of course, it's more difficult than an average melanoma patient to get an easily resectable lesion. But in the end, it ends up of what is the definition of resectability. We have done from liver metastases, from bowel metastases, sometimes you can do everything infected because it's from the bowel, but you can do it for everything. You can do from a brain metastasis, and there's not been seen so far major differences.
I can tell you, we put a bunch of people on that study, and several of mine were among those that fell victim to attrition. And we typically did sort of wedge resections, but sometimes you can't cut through tumor easily. So a lot of times you get in trouble and end up taking a bit more than you'd wanted to. But the problem is you wait until progression, and then you harvest, and then you can start a treatment in between to sort of buy time. But we don't have a lot of good stuff that works in between. And a lot of times patients continue to get sicker and are just too ill to get high-dose IL-2, which is such a nightmare. So I think it's very exciting stuff, but it's hard to see how it's going to be scalable until we identify who best to use it in.
But 1 centimeter is sufficient, as 1 cubic centimeter is sufficient typically for every patient.
And you flashed it very briefly. The cost, was that $400,000 that you said?
So what I presented was that it depends on who is doing the treatment. Because if you do in-house, like we do, it costs around $50,000. We don't know what's going to be the price from the companies. But what we know is what the price for CAR T cells. That's 480,000, if I remember well. There is this study from India where what they did themselves this CD19, of course not with the same patent, but with an equivalent CD19, and they ended up calculating $35,000 per patient. Something that's been doing especially good here in Spain. I think in Barcelona there is groups that do CAR T cells on an academic level. They make them and they give them to the patient. Now, it's not the same patent, it's not the same lentivirus, not the same construct, but it's still a CD19. So if you believe that all anti-PD-1, for example, are equivalent, then all CD19 will be equivalent.
It's working. I think it's not working, but anyway.
I can hear
close, you can hear.
You don't work.
What do you think all this trial, even in first line with lenvatinib and citrabatinib, or this kind of drug that usually we thought that can work in the combination with chemotherapy, fail?
So,
I'm sorry, for instance, the LEAP-007 in first line, pembro plus lenva, in PD-L1 more than 50%.
Yeah, so this is the anti-angiogenic agents you're talking about. So
But not only antiangiogenic, it's a time also inhibitor because.
Yeah, so I think again regarding the TAM, I think it's really very complex. We need to understand better who to target with these drugs. Regarding anti-angiogenesis, it's been a very long battle with lots of disappointments. It was considered to be the best way to fight cancer at some point, but it's been overall very disappointing. Why?
It's curious because
it's
it was positive in endometrial carcinoma, for instance, pembrolizumab.
Yeah, yeah. I think lung cancer is very genetically unstable, very heterogeneous. So I think it's a very tough target to treat effectively because there are multiple mechanisms of resistance, I think, which are happening at the same time in every tumor.
Yeah. Right. Any question, or we can finish this session and to pass to we have the coffee right now.
Okay.
Okay.
Thank you.